Right. Thanks, Christy and Jeanette, for having me here today, and thanks for everyone who took the time to come today. And one more special thanks to everyone who submitted questions in advance, because I think that always kind of makes the talk a little bit more interesting and a little bit more robust when we have your questions to be answered. So I'm just going to make sure that my slides are properly advancing. There we go. If I can, okay, perfect. So just a quick disclaimer at the beginning. This presentation is intended for education and information, but you should always seek individual consultation from your own healthcare providers. So none of the kind of medical advice that you receive today is specifically applicable to you. You want to seek your own care. So in terms of the agenda, we're going to be covering several different topics at different levels of detail. So first, I'm going to answer some questions related to driving with dementia. Then we're going to skip to talking a little bit about kind of the new medications for Alzheimer's dementia. Then we're going to switch to talking about accusations, paranoia, suspiciousness, delusions, confabulation, which is making things up, and disinhibition. And then lastly, we're going to kind of talk about some strategies for coping with those things and talk about treatments that are available from a medication and non-medication perspective. So the first question, so how do you know if someone with dementia is safe to drive? So in terms of the answer to that, having a diagnosis of dementia does not automatically make someone unsafe to drive. And adding to that, it's not necessarily the single performance on a single cognitive test that determines someone's safety. So we're going to talk a little bit more about that. So in terms of red flags that you can look for in someone with a memory impairment to know if or not they may or may not be unsafe to drive are, number one, sort of getting lost or getting geographically disoriented. The next big one is ability to stay in your lane. So people will start to weave a little bit more. They might go on the shoulder. They might cross that center line. They just have difficulty with that aspect. The next thing is driving too slow or driving too fast, right? I hear all the time, if someone's a great driver, they drive really nice and slow. And, sometimes there is a too slow. So just being in tune to that. Becoming confused or muddled in intersections, difficulty with turns, especially left turns, right? Where you've got to really figure out which lane you're going to be going into. Maybe stopping inappropriately or going inappropriately. More difficulty navigating other drivers or avoiding collisions, and just trouble remembering the rules of the road or particular signage. The other thing that you can kind of use to determine if or not someone might be safe to drive is to think about how they function in other areas. So our medical guidelines sort of suggest that if someone needs help with a basic activity of their daily living, so like getting dressed, for example, like, they can't get their clothes on properly, that's a sign that they probably shouldn't be driving, right? And with the higher level activities of daily living, if they have impairments in, say, 2 of those, they're probably going to have impairments in driving ability as well. So say ability to, organize and understand all of their medications and ability to cook a meal, for example, probably driving is going to be affected. So those are some things that a person can look for. In terms of how does the doctor assess it, because again, I said it's not just like one single test. They are sort of doing a multi-component driving assessment. That's what's kind of recommended by our guidelines. So it involves kind of looking at a bunch of different things. First, our guidelines tell you to look at the symptoms that people have. So let's say someone has hallucinations or they're very agitated or aggressive. It doesn't matter how they perform on a cognitive test, they may not be safe to drive. The next thing is looking at the functional ability, kind of like how I described. Then they suggest talking to the caregiver and looking at for those red flags of driving that I kind of described. Then looking at the person's physical and medical issues. So for example, if they can't turn their head to the side, or if they're really slow in making movements, you would take those things into consideration, making your assessment. Looking at vision. So if anyone has poorer vision than 20/50 when you examine both eyes together, or if they have a loss of a visual field, so like a cutout of half of one eye in terms of their vision, or if they have double vision, for example, you would take that into consideration. You look at their medications, for example, if people are taking like an opioid pain medication, that might impair their ability to drive, or cannabis, for example, that might impair their ability to drive. Then you look at the cognitive testing. So specifically some of those things around copying a picture or drawing a clock, those kinds of things. Then you look at sort of their processing speed, and that's where we'll have people do sort of connecting the dots kind of tasks. We might look at someone's reaction time. So for example, holding a ruler above their hand, dropping it and seeing if they can catch it before it hits the floor. And then just sort of looking at someone's insight and judgment. So after a doctor kind of goes through all of that, they sort of sort people into kind of buckets, those that are probably safe and where we'll have to kind of reassess that driving ability in 6 to 12 months. Those are that are probably not safe, and those that are sort of in the unclear kind of middle category. And then those that are kind of in that unclear or middle category, we often would recommend that they do a functional driving assessment. And I've put the link to the MTO functional driving assessment fact sheet. But that's basically an on-road driving test where you would go with a driving instructor and an occupational therapist, and they would take you on a various driving course and make sure that you can kind of do sort of all of the required maneuvers. And then they also try to make recommendations to help you to keep driving, right? So if you need, a different mirror because your neck doesn't turn a certain way, they would help you kind of make those modifications. So another question that I get asked frequently is, so my loved one is going to retire from driving. Well, what happens next? What letters are we going to get in the mail? That kind of thing. So to answer that question, I usually recommend that people kind of stop driving like that day that we talk about it. And just the reason is, with respect to car insurance, they will always ask, has a doctor told you that you're not safe to drive? And if that's the case, they're probably not going to cover you, if anything should happen. So I usually say that day is probably the day to stop. And then in terms of logistical things, within about 2 weeks, the government will send you, or the MTO will send you a letter just saying that, you've been flagged that you might have a medical condition that affects your ability to drive. Please let us know if your condition has improved, or here's some information about a functional driving assessment. And they usually put kind of a deadline on that letter. And so if you don't respond to that letter, then they'll send another letter out that says, we didn't hear anything from you, so your license will remain suspended. And sometimes families like to have that information just so that the loved one with dementia who might be very traumatized by this whole process, they can kind of anticipate what's going to be coming in the mail. Another question I get asked is, someone's worried about someone's driving, but they just passed, the Ministry of Transportation testing that goes on at age of 80. So if the Ministry of Transportation thinks they're okay, then they must be okay. And how does that all kind of work? And I think the thing that you have to remember is the goal of that Ministry of Transportation screening is to actually keep people driving. So it involves like a vision test, they review your driving record, they do some education on strategies that older adults can use to keep driving safely. And then they ask people to draw a clock and place the hands at the time of 10 past 11. And, there's a lot of kind of coaching that goes with that, because if you can't do that, they usually recommend that you do an on-road test. And so I guess what I'm just saying is this type of assessment with an MTO person, where you pass the clock draw, is not equivalent to all of the things that go into someone's ability to drive. So it doesn't always pick up people that may not be safe to drive anymore. Another question I frequently get asked with regards to driving is, what if someone refuses to stop, or they forget to stop, or how do we handle this when it comes up, every day after they've been asked to stop driving? So one strategy is to kind of use like clear, simple statements that don't require a person to remember or reason. So rather than saying, remember the doctor said you couldn't drive, the ministry sent you that letter about your license, you could try something like, I'm going to drive today, or it's my turn to drive today, just so that you're kind of, that person has less time to sort of think and worry about whether they're supposed to be driving that day. Another sort of strategy that you can use is to just kind of acknowledge those really difficult emotions, because we know that retirement from driving is extremely difficult, especially when a person lives in a rural area. And so the example would be, instead of saying, don't be angry, it's for your own safety, which is often invalidating to someone, right? Saying like, it's impossible not to feel angry that you can't drive. I'm so sorry this has happened. I wish it was different. I'm here. We can try to work through this together. Another sort of strategy, if someone, has sort of significant cognitive impairment that they really can't remember or reason anymore, it's just kind of entering the world with that person to try to find an explanation that makes sense to them. So instead of, you remember we sold the car because you lost your license, or, I unplugged the battery because you lost your license, try, something like the car's being serviced, or the car requires servicing, or the car's not, it's not here anymore, it's gone to the shop, that kind of thing. In terms of, what you can do if you're starting to think about someone's driving, or just how to handle it when your loved one might have a memory condition and they are still driving. These are some things that I kind of encourage people to do. Is to speak about it early and kind of often. And what I mean by that is, every time I'm seeing someone with memory, I always kind of mention driving, and just to say that, at some point, everybody with a memory condition has to stop, and we have to figure out when that point is before there's an issue. So maybe we can start kind of thinking about it now, as how you're going to get all the places you need to get. So when you're a loved one talking to someone, thinking about, is there someone who would be the best person to have that conversation? Like maybe it's a spouse, but maybe it's a child, or maybe it's a neighbor or a best friend or somebody else. So just kind of thinking around who's a good person to have it, just kind of validating and saying like, I know driving is really important to you. Have you ever thought about that you might need to stop driving at some point? When do you think that point might be? Do you have any ideas of, if you're not driving anymore, how could you get around? My second kind of bucket of tips is just making the retirement from driving kind of gradual. So kind of how I mentioned before, like just offering to do more of the driving. So for example, if they always go to get their haircut, just saying like, I'm available on Thursday to take you for your haircut. The next thing would be kind of organizing carpools with friends, right? So if someone always goes to an exercise class or to a coffee club, before it becomes a big concern, is just talking with a friend who could always pick that person up to take them to that activity, just so it's not a big shock when that retirement happens. The other thing I would say is to drive with people, right? So that you can see some of those red flags that are happening. So you actually know, is there a concern or not a concern? And then, if you're concerned, you've driven with someone, you are concerned, I would discuss it with your healthcare provider. Sometimes they are willing to talk to you depending upon whether they have an awareness of how much memory difficulty someone has, and if you're the substitute decision maker. But if they're not able for whatever reason, you can always write a letter and kind of comment on some of those red flags that you're seeing. And just the other thing is the police can also report someone's driver's license. So I've had circumstances where, people don't want to go see their doctor, or they don't even have a doctor, right? Sometimes the police, the non-urgent police line, and just calling and saying you're worried about someone can get some help for that person to keep everybody on the road safe. So I hope I've answered kind of some of the most common questions that I get around driving. I know that Christy had said that there's an upcoming workshop on driving and memory, and this is a new website that it is Canada-wide, but they have Ontario-specific links within it. And if you go to the website, it asks you to decide whether you're someone that has a memory impairment, whether you're a caregiver, or whether you're a healthcare provider. And then it asks if you're still driving, or if you're not driving, and it has just tons of really great resources and even some videos on how to have, some of these difficult conversations. So I would definitely encourage you to check it out. And I know it'll be coming up again at one of the Alzheimer's Society's upcoming education. So again, please put your questions in the chat. And if I can't see the chat while I'm talking. So if there is something, Christy and Jeanette, let me know. Okay, so we'll kind of shift gears to the next topic I was asked to chat about, which is new medications for Alzheimer's disease. So to kind of set the framework, last year I did a talk where we were talking about treatments for dementia, and we talked about cholinesterase inhibitors, and we talked about memantine, and we talked about sort of the risks and benefits. But I think the thing to highlight about those kinds of treatments is they are sort of designed to help the symptoms of dementia. They don't actually affect the process that is going on in the brain. So we hope that they help with the person's cognitive abilities and their functions, and they might change some of their emotional responses, but they don't kind of cure that underlying process. So the thing with these new treatments is they're actually kind of more targeted to try to affect the actual disease process. So to understand that, things to kind of be aware of are, there's two kind of broad reasons why people get dementia. One is vascular, right? So you can think of, that there's a blockage in the blood vessel in someone's brain, causes damage to an area, and then there's an impairment. The other big kind of clump of reasons why we think people get dementia is because an abnormal protein deposits in the brain. So that's kind of my squiggly little guy here. I don't know if you can see that, but an abnormal protein deposits in people's brain, and it causes damage to the cells, and then those cells can't work. So in Alzheimer's disease, for example, the abnormal proteins are called amyloid and tau. In Lewy body and Parkinson's dementia, they're called alpha-synuclein. And in frontal temporal dementia, there's several different ones. There's tau, TDP43, FUS, and there's others. But basically the point is that these new treatments are trying to remove these abnormal proteins from the brain with the hope of actually affecting the disease. So in terms of how researchers are thinking about that, how they're kind of going about that, one way is thinking about a vaccine. And there's several vaccines that, so far have not been successful, and there's a couple more still that are in active study. And that's basically the idea that the same way, getting a vaccine for measles tries to, prime your immune system so that it will fight off measles if it comes near you. The same thing with these vaccines is they try to prime your immune system. So if that protein tries to deposit, your immune system will automatically clear it out. So that's something that's under study. the new medications that you're seeing in the media right now follow under the second category, which is antibodies. So the third and the fourth one down there, the aducanumab and the lecanemab, are the two that have sort of been in the news recently. And what they kind of do is you're going for an intravenous infusion that puts antibodies into your bloodstream. Those antibodies then go find those abnormal proteins and get your immune system to kind of clear them out. And that's what we're going to talk a little bit more about today. And then the last kind of class is these enzyme drugs. So they try to block the machinery, if you will, that makes these abnormal proteins in our body. And that's a medication that is the most recent one they've been trying for that. The study was not positive in it, so it's not going forward, but people are still looking at possible solutions within that category. So thinking about those antibody medicines, thinking about who it might actually apply to, these medicines are applicable to people that have Alzheimer's disease, so that amyloid protein depositing in the brain. And there's a couple other conditions which have not been studied, but these conditions also have some amyloid depositing in the brain. So these people may possibly be candidates for these types of medications. Sorry, everyone, my slides are shifting around. And the figure that I have there is just so that you can kind of see, this is called a PET scan. So basically the figure, the brain at the top, you can see all the different colors, but there's very little of that red and orange and yellow color. That person does not have amyloid in their brain. And then this person down here, you can see this red and orange, that's amyloid depositing in the brain. So it's just kind of highlighting that in order for anyone to be eligible for these kind of new medications, we have to know that they actually have amyloid in their brain in order for these drugs to be kind of relevant to their condition. So those people that have these other proteins or these vascular things, they will not be eligible for this type of medication. The next kind of thing to just remember is that when they've checked these drugs in people with sort of a late onset of disease or even a middle onset of the disease, the medicines have not been shown to prevent the disease progression. So we're really just talking about people in the very, very early stages of illness. And I put the kind of the score there in case that's of interest to you, but basically it's people with a mild cognitive impairment or a very early stage dementia who are functioning really well in other categories, who are kind of even possibly eligible for these medications. And I know that's, that's a big thing for a lot of people because they might be coming in a middle or a later stage and wondering if they might be potentially eligible. And unfortunately, in that situation, the risk of the medication often outweighs any possible benefit. In terms of like, what is the treatment? So what we kind of talked about how it would be intravenous, but it would be sort of similar to having chemotherapy in the way that it's an intravenous medication. It's given every 2 weeks for, in the studies, it was given for 18 months, but we don't really exactly know how long it would be given for. People would have to have that amyloid scan, the amyloid PET scan before doing it, so we would know if they have amyloid in their brain or not. And then there would be some MRI scan monitoring, just because this medicine also has some side effects. So in the Canadian context, it's something to think about because we don't really have chemo type suites for people to receive these kinds of medication therapies, right? It would be a completely new thing that we have to think about as a healthcare system. So the other kind of thing to talk about, and the reason why these medicines are kind of controversial, I've tried to kind of summarize it a bit in this table, and then we'll break it down a little bit more. But basically, both the aducanumab and the lecanemab have been shown to remove amyloid from the brain. So again, I'm hoping you can see my mouse, but this is someone here on the left who's got a whole bunch of amyloid, the red, orange, and yellow in their brain. And after doing 1 year of treatment with these medications, you can see that all that red and orange is gone. So all the amyloid is gone. And we definitely know that these medications can successfully do that. So on that basis, the FDA in the United States, which regulates all the drugs in the United States, approved aducanumab in June of 2021. And then they approved the lecanemab just recently, the last couple of weeks, so January 2023. And they approved it on that basis of, being able to remove that amyloid and the fact that there's sort of no other treatments that work that way available. The problem and the reason why we have to, be cautious when we're thinking about new treatments is that that removing the amyloid has not yet been shown to actually improve people's, cognitive symptoms, function, emotional and behavioral changes. And so when they've come out with more data from aducanumab, the initial data hasn't really conclusively shown that it improves any of those outcomes. And so the FDA is making that drug company do another study, which we're expecting that in roughly 2030. So quite a while before we would have a little bit more conclusive information. And with the lecanemab, the drug company has reported some benefits, but we're going to talk about that and try to decide, how do they apply to the average person? Are they really relevant to the average person's experience? The other thing to balance that with is just the risk of side effects. So unfortunately, these medications, when you use these antibodies to pull these proteins out of the brain, that can cause swelling and bleeding. And so that's a big concern. And in terms of the status with Health Canada, because I know, knowing about approval in the United States, that's great. The aducanumab, they actually withdrew their application to Health Canada. So at this time, until they have more data, they're not pursuing approval in Canada. And we don't know if the lecanemab will apply in Canada. In Health Canada is very rigorous, and I think it's the reason why aducanumab probably withdrew their application is because they're concerned that just by showing they remove amyloid without showing functional improvement, that they may not get approval in Canada. So these are kind of the side effects that I mentioned. So on the left side here, this is the area E, or the amyloid related imaging abnormalities edema, which is the swelling and its part. And then on the right side, this is showing the area H, which is the hemorrhage or the bleeding part. And that's just these they're micro hemorrhages, so little tiny black dots. A person could have a larger hemorrhage though as well with these medications. The next kind of side effect to think about is these infusion reactions. So about 1 in 5 people also could have an infusion reaction where you have like an allergic reaction kind of thing. And the last thing, and probably most concerning, is just that the swelling and bleeding could get so bad in someone's brain that they could actually die. And so lecanemab has had 2 deaths and another one that's currently under investigation. So that is why there is a lot of caution around those adverse effects. We hope that we would find a way to figure out who's at risk of those side effects and, make sure that those people are not getting these medications, but it's a concern that's not yet fully understood. So I'm hoping everybody's still with me, but in that summary slide, how I said aducanumab, we don't really know how it affects, quality of life and function and that kind of thing yet, because they were told that they have to study it more. But the lecanemab, we have sort of this initial data. And what you will see, so this is the graph that kind of they published. What you will see, so time 0 up here at the top when people first enrolled in the study, and people who got the lecanemab drug declined. People who got the placebo drug, the blue line, they declined. So everybody is unfortunately still declining. The difference at the end of the 18 months of the study was about 0.45 points on that scale, the CDR scale that we talked about. So, the concern is as a doctor is that we sort of think that you'd have to have about 1 or 2 points difference on that scale to really, be sure that that is an actual clinically meaningful, functional memory difference, right? That people are going to notice, that's going to really kind of set people apart. Having less than half a point difference, we don't know if that's just statistical, if that's just a statistical phenomena, or if that actually means things to people's, daily function. So I think that, the bottom line is that people that suffer with Alzheimer's disease and every kind of dementia, they really deserve a treatment that is both safe and clearly effective. And at this time, although a person can travel to the United States to access these therapies, there are still a lot of unanswered questions that should give us all pause. So, my biggest recommendation is still that prevention remains our very best defense against dementia, and that the medications that we've had around for a long time, although the benefit they provide to people's symptoms is modest, they are considered sort of generally safe. And I've just put a link to, a good link on the Alzheimer's Society website to information around kind of dementia prevention and that kind of thing. So again, I hope if Christy and Jeanette have any questions, they'll pause me, or we can also wait till the end, whatever's easiest.
I don't have any questions that were sent to me just yet, so we'll just keep going.
Okay. Okay, we'll keep trucking. So into kind of our third topic, which was kind of why, do people with dementia kind of start having some of these behavioral and emotional changes? So kind of specifically, I was asked about accusations, confabulation, suspicious, paranoid, delusional kinds of things. So let's kind of define that just so we all understand what we're talking about. So, confabulation is, making up an imaginary experience, basically. And often that's a compensation for someone's memory loss. It's easier to sometimes make up something, right, than to not have a blank space in your brain. Accusation is kind of claiming that someone has done something wrong. Being suspicious is just kind of a cautious distrust for someone, if you will. Paranoid is kind of an unjustified suspicion or mistrust about a person or their actions. And then a delusion is kind of like a fixed false belief. But it's all, I kind of think of a lot of it as sort of on the same spectrum. So, if we give the example of someone that can't find their wallet, if they confabulate, it would be, I lost my wallet last week at church, when they didn't even go to church last week, right? If they're accusatory, it's, oh, I think you took my wallet. If they're suspicious of someone, it's, I don't trust them, they might have taken my wallet. Paranoid is, barricading the doors each night because I want to keep those wallet burglars out. And the delusion is sort of that ongoing idea that, for sure the neighbor has taken the wallet, and, they're, very stuck on that certain topic. So that gives you some examples of kind of those different terms. So in terms of why this happens, what generally happens to people is they sort of have their past knowledge, past experience that's fairly ingrained in their brain. And then we've got the dementia process, which is affecting that ability to work with new information or to make new memories. And then you have sort of like the current circumstance. So again, using the wallet example, their past experience might have been that they always kept their wallet in their bedroom, forever. That's always where it was. And yesterday it got moved around for whatever reason, but they don't remember that, right? So now they're in the current circumstance where they only have that past knowledge or experience, and they have to come up with a reasonable explanation for what has happened. So, they can't find it. They're feeling more anxious. They've lost probably their credit card, their ID card, and you're sort of that only one there, right? And so you're often kind of the target or the only possible explanation for what's going on. And add to that, if a person has disorientation where they're not oriented, to time or place or person, if they can't recognize people, if they have a vision or a hearing impairment, of course, all of those things are going to add to, the degree to which the current circumstance is manipulated in their brain. So in terms of kind of how to deal with that, many people don't have insight into the reality. So I think one of the hardest things is resisting that urge to apply logic and reasoning to what's going on. So if we're not going to we're not going to default to applying logic or reasoning, like what are we going to do? So these are just some kind of general strategies that you can use. So one is like your affect and your body language. So you want to remain very calm. You want to keep in a gentle tone of voice rather than kind of matching their escalating tone of voice. You want to make good eye contact so they don't think that you're kind of looking guilty, if you will. You can use kind of touch or anything that's comforting, right? So maybe like holding their hand or kind of offering a hug or putting an arm around the shoulder so that they kind of can feel that you're with them there and what they're experiencing. You want to acknowledge what they're saying in terms of kind of acknowledging that emotion that they're having and kind of reassure them that you're going to help them work through it. So kind of an example would be like, don't say, I didn't take your wallet. I'm your husband. Why would I ever take your wallet? You probably misplaced it, which is the logical thing. Just say your wallet's missing. Like, you're worried. I'll help you find it. We'll work together until we find it. In terms of medications for treating this group of symptoms, there's no medications that are specifically approved to treat these kind of psychotic, we call them type symptoms in people with dementia. There is a medication that is approved in the United States but difficult to access in Canada and not covered, called pimavanserin, which has an indication in Parkinson's disease with psychosis, but it's not approved for anyone with any other kind of dementia type condition. Another medicine that we sometimes try would be a cholinesterase inhibitor, especially for people with Parkinson's and Lewy body, because again, they seem to get a reduction in some of those psychotic type symptoms with that medication. As a doctor, when I am looking at someone who might have these kinds of symptoms, sometimes I try to target, surrogate things. So I might try medicines for anxiety, for example, or I might try medicines for depression if those are big parts of what's going on. I might try treating agitation, like if someone is getting agitated or aggressive. I might try treating pain, for example, because sometimes that can make people feel more worried and heightened, and all of those psychotic symptoms can come out a little bit more. And then another kind of, again, medications that we sometimes use are antipsychotics, which are, they were initially developed for psychotic symptoms related to schizophrenia, but in people that suffer with dementia and psychosis, sometimes we use some of those same medications in low dosages as a trial to see if that might help someone with some of those symptoms. So in terms of the take-home points, I would say around the medication, I think it's sensible, to have a specialist sometimes involved in when those kinds of symptoms are going on, just because it can become a very individualized decision as to which medication we're going to choose to target which kind of symptoms. The next thing I would say is that medications are always a trial, right? We're always trying it, for 2 or 4 weeks to see how does that impact someone's overall quality of life? What are the risks? What are the benefits? And if it doesn't work, right, we can go try something else. We always try very low dosages. We always want to reduce the symptoms and usually not cure the symptoms. And that's another thing that I wish when people come to me with these kind of symptoms that are really distressing, I wish I could make them be zero, but sometimes we can't make them be zero, but maybe we can get the quality of life better. So just kind of always asking your healthcare provider what that goal is. Is it zero or is it just better, or what are we aiming for here? And then just remembering that it has to be balanced with side effects, right? So every pill we pick has a different side effect profile, and we want to balance that out with the person that we're treating. So we've got just a couple more slides to go, and then we'll kind of jump into the live questions. But another question was sort of, why do people become disinhibited, and kind of what do we do about it? So in terms of what is disinhibition, it's sort of a lack of restraint, if you will, or just sort of a disregard of social conventions, or the person being really impulsive, or just doing a really poor risk assessment. So it can include things like making tactless remarks, sexual comments or sexual behaviors, taking your clothes off in an unusual place, touching yourself in a way that you wouldn't typically in public, or just being really impulsive. The reason why that happens is because of damage to the frontal lobe of the brain, right? That's the part of the brain that regulates our behaviors and our emotions and our judgment. And so if you damage that, people are going to do the first thing that comes into their mind, whereas before they would have kind of tempered that with using those sort of higher level frontal lobe functions. So one of the things that I think caregivers find generally helpful if they have a loved one that has a lot of disinhibition is carrying one of these companion cards, so that if you're in the grocery store or, in the hair salon and someone has made a really inappropriate comment, you can kind of hold this up behind or just pass it to the person. And it just says, the loved one that I'm with has a memory condition, and, I appreciate your patience, just so that they know, not to take that personally. I think just other kind of general coping strategies, avoid logic, avoid scolding people, like don't bother with, well, that's a terrible thing to say, and try to just remain calm, try to redirect or try to distract that person onto a different topic as best you can, or change the environment. All right, so this is a question that we received just in the last couple of days. And so I kind of took it kind of verbatim and then wrote some possible answers on the next slide. So I'll just read it out loud to you. So my loved one has Lewy body dementia, and she experiences hallucinations almost every day. They make her feel frustrated, confused, and sad, and occasionally scared. We know and use the technique of validating her emotions and then distracting. Sometimes that works for a while, but then she returns to what are, for her, very real and important questions. Why don't they talk? Why don't they go home? Where do they live? Isn't it rude for them to just sit there and stare at us? How do we get them to leave? I have never seen anything like this. What should we do? Can we call the police? She's asking these questions of the people that she loves and trusts. And when we can't answer these direct questions, she gets understandably frustrated and confused. I am concerned it's ultimately going to cause her not to trust us or believe what we say to her. So in terms of just some thoughts that I had when I kind of read this statement, and, Christy and Jeanette probably have some thoughts as well. But something that sometimes helps in people with Lewy body dementia is using a little bit of logic and kind of validating their overall experience. And what I mean by that is saying something to the effect of, people with Lewy body disease have this abnormal protein depositing in the brain, and it damages the vision areas of the brain. And so it's really common that people have these types of visual misperceptions where they might see a coat rack and think that it's a person, or even the visual hallucinations like this person's having. And just kind of validating and saying, you know, this is part of the disease. You're not making these things up. They're very real for your brain. They're very real to you. Sometimes that kind of validation can be helpful. The next thing that I've kind of thought of with looking at this case is kind of thinking about triggers. You know, for some people, because there's a misperception aspect to this, removing things that are more likely to be misperceived as a person sitting there can be helpful. So, you know, covering mirrors, getting the best possible lighting, and just getting rid of any kind of shadowy areas. You know, closing blinds at night so you don't have that kind of peeking out the blinds to see if there's something kind of going on out there, or just removing any object that's misperceived. Another thing that might be helpful, in addition to the kind of distraction that this family's using, is just kind of changing the environment. So saying something like, you know, you're feeling upset that they won't leave. Let's go out and get coffee and see how things are when we get home. So that idea of kind of going out and coming back and seeing if the visions are gone or different. Thinking about time of day. So many people sort of have this sundowning aspect where towards the end of the day, as their brain gets more fatigued, they have more problems with the visions. So encouraging some other activity during that time of the day, whether it's going for a drive, you know, before the visions get really bad, or going for a walk, or, you know, planning a family game night or whatever it is, right? Having something to fill that space so you're not just kind of sitting there waiting for the visions to start up. Taking breaks, and so both for the family and for the person with the memory impairment. It can be exhausting to be at home and having these visions all of the time. You want to give both the person and yourself a chance to take a break from that, right? So thinking about going to a day program or a program, or family thinking about, you know, rotating, like having, you know, someone's going to be providing the care for a certain period of time, and then someone else is going to be providing it, just to kind of reduce that emotional fatigue. And the last thing I would say is to talk to your doctor and your support counselor. This is a situation where perhaps it would make sense to change a medication, maybe something targeting anxiety, or maybe something targeting the hallucinations in general.
We had a question kind of related to this, so I just thought I'd bring it up. And it's about validation therapy. You were mentioning a bit about validation there, and there's a particular train of thought with validation therapy from Naomi Field. And somebody was wondering, you know, in terms of the Canadian healthcare support system, or medical training, do you cover some of those kind of, or how is that supported in the Canadian medical system, support system?
So how is validation therapy?
Yeah.
Oh, goodness. So, so for example, supports such as, so I'm going to preface this with saying I'm not totally familiar with the literature around validation therapy specifically. When I use the word validation, I'm just referring to validating a person's emotion, right? Without agreeing or disagreeing. It's just like, you seem upset, you seem worried, you know, giving them that empathy and using some of those nonverbal cues to kind of acknowledge that emotion. But in general, there is not a huge funding pot in the Canadian healthcare system for specific rehabilitative therapies for persons with memory impairment. So for example, cognitive training. We have, of course, the Alzheimer Society provides all kinds of wonderful programs, partly through government funding, partly through your donations, right, that are targeted at this. But like, for example, one-on-one specific cognitive training therapy isn't really covered. And so I would say it's probably the same for something specific like a validation type of therapy. But I would always encourage people to be involved with the Alzheimer's Society, because, for example, programs like the recreation therapy are a really good way to get that one-on-one time to work on something like that is not part of their person's usual day, and to really kind of get that brain going and distract a little bit from some of those other symptoms that are going on.
Yeah.
I don't know, Christy or Jeanette, if you would have anything else to add to that.
No, that's terrific, and certainly, you know, at the Alzheimer's Society, like you mentioned, we do have some information about that as well. It can be a great support for family caregivers. You know, just can provide some, I guess, tools to help them cope with the day to day. But thank you, Dr. Peel.
So is that so I mean, I think of therapy, I think of cognitive behavioral therapy, dialectical behavioral therapy, problem solving therapy. It's sort of along that line, but more directed to caregivers, or both?
I would say it's from what I understand about it, it's directed more towards family or professional caregivers, and it's just sort of a whole field of it's an approach developed by a social worker, like I said, Naomi Field, and it is used in some of the long-term care training, community care training. We incorporate it in some of our information as well. So for the person that asked the question, if you want to contact Christy or I, we'd be happy to address that as well.
Yes, it was developed, if I remember correctly, in a direct reaction to reality therapy. And so particularly in the field of supporting people with changing cognition, reality therapy is often highly ineffective. And so validation therapy went the opposite way. And let's not try to use, just like you said, Dr. Peel, not using reason or facts, but let's validate the emotion, let's validate the experience, and let's find a way to work from there. So yeah, please do reach out if you have more questions about validation therapy. Jeanette or I could hook you up with some more information. I've got a couple other questions here. Someone asked if you would mind to speak on donepezil, Aricept. Is that something that you could chat to us about for a moment?
I mean, I could chat to Jeanette on donepezil or Aricept all day long. So you're giving me a lot of license with that question. I think so. The things to kind of think about with donepezil, I guess number one, like who kind of is it indicated for? The most, or it is used in Alzheimer's disease. It can be used in some types of vascular dementia. It's used in Lewy body and Parkinson's. The main category where it's not used would be frontal temporal dementia, just because it seems to make people be more disinhibited, or just seems to make their behavior worse rather than better. So that would be maybe the first thing. In terms of determining if someone is a candidate, you need to have an ECG before you would think about doing that therapy. So that's one of those, they put the little leads on your chest and they measure the electrical activity. You have to have a heart rate above about 60 and not have any slowing areas in the conduction in the heart, so called a bundle branch block, because donepezil can slow the heartbeat. So basically, we're just trying to make sure that everybody has a heart rate of at least a threshold before we would start that medication. And then kind of thinking about, potential benefits and potential risks. So from a benefit perspective, when people with Alzheimer's take donepezil, 1 in 42, notice an improvement on their memory test score. About 1 in 12 notice less decline. And that less decline applies to functional subscales and kind of memory subscales. And for certain people, there's certain behavioral things that might improve with that medication as well. In terms of adverse effects, about 1 in 12 people experience an adverse effect that would lead them to want to stop the medication. A lot of that is stomach upset, diarrhea, those kinds of things. But it can also make people feel that they might have to pee more frequently, which is a problem for a lot of people with memory impairment. Some people experience some nightmares with that medication, can make your nose run a little bit more, make you to have more phlegm in your throat. So those are, you know, some general things to think about. So with all of that information in mind, again, we tend to offer it as a trial, right? This is a trial to see how it might affect your memory and function. We know it's not a cure for the illness, but perhaps it might slow the changes that you're experiencing or help things be better on the day-to-day. The other thing I would mention is just about when we stop it. You know, the medications in studies are often for 6 months, right? We don't really have studies of people taking these medicines for years and years and years. So for many people, they end up stopping when, you know, either the function is so impaired that there's not a lot of function that we're trying to preserve, or maybe they are having side effects, which become more of a challenge as the illness progresses. So that for a lot of people, that's kind of when we would stop. You know, if people can't take it reliably because they can't remember to take a medicine every day, that's another time when we usually stop, because I don't really want people coming on the pill and off the pill and on the pill and off the pill. They're more likely to get those stomach side effects every time they kind of do that. So I hope that answers the question, but that's kind of donepezil in a nutshell.
That's great.
Yes, that's absolutely great. Lots of information, some side effects that I was unaware of. So thank you for that. Next question I was asked about PET scans and their availability in Canada.
Yeah, so right now, so a scan that is available in Canada in some circumstances is a SPECT scan. So it's a little bit different. What it's looking at is glucose utilization in the brain. So basically they give you this radioactive, they like inject a radioactive tracer that tags the glucose, and it goes to the brain and it sees what areas are using the glucose and what areas are not. And from that, they try to get more information about what kind of process might be going on in the brain. So that's a SPECT scan that would be available like at any of your kind of tertiary centers. We only use that in circumstances where we're really just not sure at all what is going on with someone. The PET scan, it's available now for people with cancer, for example. So if you have a lung cancer, they're doing a PET scan is available. But this specific amyloid PET scan that's being used in the Alzheimer's research is only available within research at this time. The injectable substance that they use for it, I guess it gathers quite costly, and so it's really just isolated to those settings right now. So the current kind of standard of care is that everybody with a memory concern will have blood work to rule out reversible causes of memory impairment. Everyone will have some type of imaging in their brain in almost all circumstances, a CT or an MRI, to make sure they don't have a brain tumor or a big bleed in their head or something like that. And, you know, everybody should get their medications looked at, and there's some other things, but right at this time, these dementias remain sort of a clinical diagnosis, if that makes sense. So that PET scan might be something that becomes available as research evolves in how it can be used, but it's not right now. The other thing that some people ask me about is lumbar puncture. So again, a test that is not considered necessary to make a diagnosis, but again, if we're really not sure, you can actually do a lumbar puncture. So similar to if someone was getting like an epidural because they're going to have a baby, they stick a little needle in the back, take out a bit of fluid, send that for sample, and you can measure the Alzheimer's protein levels and try to get a prediction of whether that person has Alzheimer's protein in their brain. But again, it's not considered kind of necessary for diagnosis unless there's some kind of uncertainty.
Mhm. Thank you. That was, yeah.
I would say to, actually, sorry to belabor the point, there is also a blood test that is available. Again, it's not readily available in Canada, but it is probably available in the United States that can measure kind of blood amyloid and tau levels and give a prediction of someone's chances of developing Alzheimer's disease. Again, I mean, my caution around going for some of those things is if we don't have that cure yet, you know, going for a lot of these tests, paying a lot of money to get information, which could be life-changing that you can't do anything about. You know, just have caution.
Agreed. The next question was a person asking if I am diagnosed with a mixed dementia, one being vascular, is it still called Alzheimer's disease? So I guess we're asking about what do we call it if it's
Sure.
mixed?
So I do get that kind of question a lot about, I think it also is kind of getting at like, what does it mean to have dementia? What does it mean to, you know, any of these conditions? So dementia, like the term dementia is a syndrome. It describes someone who has a decline in a cognitive test score and a decline in their functional ability. So, and we have to say it's not due to an acute medical condition and it's not due to a psychiatric illness. So that's what dementia means. And then there's a whole bunch of kinds that if you think back to that slide where I showed you, like there's the protein and then there's the vascular blood vessel issue. People have various distributions of those types of problems going on in our brain. So when we say someone has Alzheimer's disease, we are speculating that their primary problem is that they have that abnormal amyloid protein depositing in their brain and causing damage. When we say someone has a mixed disease, we are saying that they have, mixed vascular Alzheimer's, we're saying that they have a certain amount of vascular change in their brain and a certain amount of Alzheimer's protein depositing in their brain. So I think the question was, do I also have Alzheimer's? And it's, I mean, technically, yes, you also have Alzheimer's disease protein depositing in the brain if that was the diagnosis that you were given.
I think that answered it. I'll reach out to that person to see if that did answer it. It sounded reasonable to me. And then the next question, I was just going to read it so I get it right. The question is, what impact does family members having Alzheimer's have on me being diagnosed with Alzheimer's? My parents and siblings have had Alzheimer's. And what tests, oops, my goodness. What tests can I have that could predict if I will have it? And we've touched on this a little bit, but
yeah. So just kind of generally speaking, so there are different genetic and environmental predispositions that people can have. So it's not a one size fits all answer. I would look at the age that your family members experienced the dementia. So if they were all younger than 65, there is a certain a set of genes that we would be more worried about. And if that were to be the case, I would probably recommend that you ask your family doctor to see like a genetic counselor, so that you can, you know, get a really good detailed look, because again, the earlier that someone experiences Alzheimer's, the more likely there is to be a significant genetic contributor, I guess I would say. For people that have family members who experienced dementia sort of after 65, there are some genetic factors at play there too, usually. But the good news is they don't 100% mean that you are going to get dementia. So it gives you the opportunity to look at those dementia prevention strategies and make sure that you are kind of living your best possible, healthiest life to prevent dementia. In terms of like what testing can people just generally get. Again, I would kind of caution you to not go get a whole bunch of genetic information just without talking to somebody specifically about your case, because you don't want to get a whole bunch of results that you don't know how to interpret. But one thing some people will do is they get themselves involved in research. So some of these clinical trials are actually involving family members of persons with dementia, and they're doing a whole bunch of genetic testing and amyloid PET scans and lumbar punctures and all of that kind of stuff, and looking at, you know, who goes on to develop it, who doesn't, sometimes testing a medication to see if it can kind of prevent. So that's one way that people get a little bit more information about some of their genetics. People, you can go to the United States and get like some of these blood tests or genetic tests, but just make sure that you've got all the information about that before you would go and do that, is what I would say.
It's important to have support with you when you are receiving any kind of diagnosis like that. Thank you.
Well, yeah, and I mean, all of these tests, they're giving a prediction, right? They're not giving often a diagnosis, but the diagnosis is clinical. So what do you do with that prediction? How does that change how you live your life? Maybe it does, maybe it doesn't. How does it affect your insurance?
Absolutely.
Absolutely. I heard,
Well put.
yeah, I heard another doctor speak recently about with the majority of types of dementia, and Alzheimer's dementia being almost 70% of all diagnosed types of dementia certainly fits the bill. You can go for testing, but that particular physician said, I wouldn't recommend it. And most doctors don't recommend it, just as we're hearing Dr. Peel say today, because even if the testing demonstrates that we may carry that gene, it's considered a risk gene. It doesn't mean we will develop the illness. So I may very well be carrying a number of risk genes, but there's no test in the world that will tell me, will I develop dementia? So is it useful information to have? I know here at the Alzheimer's Society, we just really encourage people, as Dr. Peel has said multiple times in today's presentation, let's just look at those modifiable factors, those prevention factors that we do have control over. Right? We can eat healthily, we can exercise, we can learn new things and be curious about developing new skills and learn new things and be socially connected. And kudos to all of you for coming out today, learning new things, right? Look at you, taking the advice already.
Yeah.
And we can keep our blood pressure good, keep our cholesterol good, you know, not get diabetes, all those things that accelerate vascular in the brain. But yeah, I hope that answers that person's question. Like, you know, you can go on to, if you're talking about genetic predisposition, right, you can go on to any of those gene, you know, the websites where they mail you out a swab and you swab and you send it back and they tell you you're at risk of all of these bazillion things. Many of them include the ApoE4 genes, which is the most common sort of genetic risk factor for dementia. But as Christy said, you know, what are you going to do with that information? Because it's a risk factor, just like smoking is, but it doesn't mean you're going to get it for sure.
Mm-hmm. Very good.
I do have one. It's a bit more specific, but if it's from somebody who's, and I know that you said the infusion is not available in Canada yet, but he was just wondering, you know, if he's already getting another infusion for an immune issue, can you just add medication to an infusion you're already getting?
So again, this drug, it really isn't available in Canada right now. So the only places you're going to see it in Canada are like within research studies. So the drug has not been studied like in combination with other things. So let's say you're getting an infusion for cancer, or you're getting an infusion of iron or something like that. Like it wouldn't be, it's not been studied in combination with that. I mean, theoretically you could probably run one and then run the other one right after, but you know, it's just, I can't give you like a medical answer to that right now. Most people who are in these studies are just getting like one thing and then they're monitoring for side effects and benefit, right?
Okay. Thank you. Okay.
This is
Christy, do you,
Yeah, I don't have any new questions. I did have someone let me know that they were very impressed with the answer to their question and just very appreciated your whole wonderful presentation. So I guess this is we've last call. Any other questions coming in?
lots of thank yous. I really appreciate when you were describing different ways that people, like looking at the concept of accusations versus, suspicious. Are they delusional? Like sometimes having the vocabulary to describe those differences can be so helpful. When you're not only when you're going to try to just as a care partner describe to your doctor what you're experiencing, but also just to sort of sort out how you're feeling yourself, what sort of behaviors you're working with. So thank you for that. Oh, I got some more messages. That's great. Excellent session. Okay.
Lots of very positive comments, very useful presentation, just gratitude.
Yeah.
Really wonderful. Thank you so much. Very practical.
Thank you.
Yeah. Great.
The time to attend.
Yeah, absolutely. Yes, we appreciate you taking time out of your day to watch, and we certainly appreciate you coming here, Dr. Peel. This was wonderful.
Great. So
Yeah.
I just put a link to the office. So again, as I said, like a person does need a referral from a primary care physician or nurse practitioner in order to see a geriatrician, but the office number is there if there's any questions. And then I did put a link to my website, which I admit I struggle to keep it updated due to these 3 young fellows that you see here, but there are some links to resources which might be useful there as well. So
Wonderful.
Okay, that's terrific.
Thank you all so much for joining us. Thank you, Dr. Peel, for giving us your time, your expertise, and this wonderful knowledge. And for those of you who are still with us, thanks for joining us. Jeanette and I would love to answer any questions you may have. Do check out our websites with ongoing education features that range from in-person sessions to online sessions. We love to hear from you. We love to connect with you, and we love to answer your questions.
Thank you very much.
Thanks for attending, folks.